Very good. So thank you so much for joining us today. And we're here to talk about how to survive the value-based payment reform, to share a few new approaches to population health, talk about how to truly implement population health in your practice, and care coordination. So let's move on and talk just a little bit about who the National Rural Accountable Consortium is and what this Transforming Clinical Practice Initiative is all about. We're a not-for-profit organization that supports rural health care. We were formed by rural providers, and truly with all of the new value-based models, they weren't conducive to the smaller independent practices. And our CEO, Lynn Barr, began to work together with CMS to find ways so that the rural providers, rural health clinics, and independent practices could be equipped and take advantage of some grant money through this Practice Transformation Network. So we were awarded, back in October of 2015, we were awarded $31 million. That was to bring on 7,000 clinicians in about, actually we projected only 550 practices over a 4-year program. This program does last, and all of the benefits and resources are available for 4 years to our providers that enroll. Well, that 7,000 as of July 20th has been exceeded, and CMS did not want us to stop recruiting. You know, in less than 9 months, we exceeded the 4-year goal with over 890 independent practices nationwide. So CMS has just extended that $31 million, and we now are going to have a goal of 11,000 clinicians because of AAFP, and thanks to Jan Kelly. We are also working with the registered dietitians and nutritionists, with specialists all over the nation, psychiatrists, and in addition to the primary care, we really are doing a really sort of carved out a niche to work with the specialists and to help them with not only PQRS and some of the other challenges they have, but as we move into the merit-based incentive payment system, it's really to help equip and provide the infrastructure to survive all of the value-based changes and payments that are coming towards us in a reimbursement. And that is the MIPS program. MIPS applies to all providers, as I said, that report PQRS in an ambulatory setting that bill on a 1500. RHCs at this time really aren't going to be affected by MIPS, although there's a huge push nationwide through HRSA and CMS to get those RHCs on board reporting quality, patient satisfaction, and clinic, and really providing some incentives for them to become PCMH, patient-centered medical homes. So let's just take a quick look at this timeline, and this is from an educational perspective only because this is new information. All providers are going to begin being measured with a performance period. The first performance period is going to be January 1, 2017. CMS is then going to make the results of that performance measurement period available in a confidential feedback report to each eligible professional, and those letters should go out and be received around July 1st of 2017. It's really going to show you a true picture of what's going to be measured. Now, most everyone has heard that Andy Slavitz has promised to make some concessions because none of our providers are going to be eligible and ready for all 4 of the new measurement requirements and areas. So we believe, but this is not in writing, that the next measurement period that's going to begin January 1 of 2018, we believe that beginning in July 1 of 2018, they'll use that information, and that's what we're really pushing and lobbying for, that they will have another 90-day measurement period in 2018, and that they will then give our providers an opportunity to implement these programs and get them in place, and then the letter that all the providers will receive on July 1st of 2018 will be the actual score and show exactly what the performance has been to the providers that they'll be paid on January 1st of 2019. Here's just a timeline that shows that, and as you can see, the fee schedule has been reduced to only 0.5% for the next 4 years, beginning this year. That's, I guess, October 1 when the new CMS year starts. And there won't be any further updates. But under the MIPS program, as you can see, there's 4 areas of MIPS quality that includes patient satisfaction. Resource use, that's cost, that's test, that's preventable admissions, that's pricing, and procedural charges. That the third is clinical practice improvement activities. We'll talk a little bit about that in a minute. That is really the patient-centered medical home measures that our practices are going to be, looking to implement. And this program provides a lot of support. And then meaningful use is going to be changed and modified. It's even called something else, but it's basically the same. With those performance measurement periods, either in 2017 or 2018, if we get the concession we hope for, won't be until 2018. In 2019, the penalties and incentives will go into place. And it's called a payment adjustment. The bottom 25% of all providers, just like it's really in a quartile, it's sort of like your children's CRCT test, the standardized test. If you should rank in the bottom 25%, that's a 4% penalty. But the good news is, and it's wherever you fall on the scale. The middle, there's a neutral period, a neutral measure that'll be no adjustment up or down, right smack in the middle. And then the highest 25%, what they're really not really promoting is it's 3 times the penalty. So if you look at this 4% penalty, if you perform highly and well, you can earn up to 12% on top of your standard E&M codes and your payments that you're currently receiving in your practice or clinic. And that goes up each year. 2020 is 5%, 2021 7%, and then it maxes out at 9% in 2022. So the bottom 25th percentile of the performers could incur a negative payment adjustment of 9 or a positive payment adjustment of 27%. And I certainly, my glass is half full, and I like to think that with the tools and resources and population health programs that we can help you implement, you will be able to earn a really nice incentive payment. And then bottom is the qualifying advanced payment models, and that's like ACOs, bundled payments, any of the pilots that are out there now, and there are more every day, that if you are participating in a qualified advanced payment model, then you get a flat 5% incentive payment. And you're excluded and waived from these MIPS penalties. So that's just a little bit about that. Here's a little bit more about those points in these measures. There's a total of 100 points, and this is how it's broken down on the performance categories. So you can see resource use is only 10% in the first year, but it's going to go up. And respectively each year, up to 20%. Then the clinical improvement activities that we're going to talk a little bit about, that's 15%. That's a self-attestation in the first year. And then meaningful use is pretty much going to be measured the same way it is now. So let's talk about what you can do to prepare for MIPS or any type of future value-based payment structures, and can take advantage of the population health payments and resources that CMS has put out there as we move from volume-based payments to value-based payments. CMS is replacing the reduction in volume with improved population health payments like annual wellness visits, depression screening, advanced care payments, transitional care management services, and chronic care management services. But this is basically to help you establish your value-based infrastructure, and everything I show you today, absolutely no cost, and it's furnished to you and funded through the CMS Innovation Project. So what is a Practice Transformation Network? There were 28 Practice Transformation Networks awarded nationwide. We are the only PTN that was offered a nationwide platform and are doing business in all 50 states. And that's because we're able to do business in all 50 states. We're in about 39 states today. And that's because we do have a small, independent, rural focus. And when I say rural, I'm really talking anything outside of a large metro area and independent practices anywhere. So that's who we are. And this project is the Transforming Clinical Practice Initiative. So going forward, I'll just refer to it as TCPI. This is what the program is. And fundamentally, when you're looking at implementing value-based infrastructure and population health, you're really identifying your sickest patients. And when you're trying to reduce cost, we understand that 80% of Medicare spending is spent on our patients with 5 or more chronic conditions. And I just include this because it's so dramatic to look to see 4%, only 4% of our Medicare population has 1 or less chronic conditions, and 96% of the Medicare expense and money is spent on those with 2 or more chronic conditions. So where do we start with this great initiative? We start with helping your practice or clinic set up their billable care coordination service. We began by, and the only requirement to participate in this program is that you hire or designate someone to serve in the role of care coordinator, because it's so vitally important to managing the health of your patients and identifying especially those referred into your chronic care management program. How do we do that? How do we provide your care coordinator with the tools and the resources she or he needs to be successful? Well, we began with a 26-hour certification called the Clinical Health Coach Certification. It is actually created by Iowa Chronic Care Consortium. It's excellent, and it teaches them to coach patients to better health. In addition to that, we have a care coordination coach that works and mentors with each of those care coordinators and holds monthly cohort calls to help them with their barriers and the challenges that they're facing. But that is a requirement of the chronic care management program to bill chronic care management. Second requirement is you've got to have the necessary IT infrastructure. And we provide you with a data analytics software with a care planning module that is state-of-the-art, and it's called LightBeam. LightBeam Health Data has a care planning module that allows you, regardless of whether you have a care planning module in your electronic health record, you can use this tool to track, to house your care plan for your patients in your chronic care management program. Or if you have a care planning module in your EHR, which we know Athena and Allscripts and eClinical and many others do, then we can transfer that data through a VPN connection and a continuity of care document, a CCD document, and integrate with your EHR. And we have an IT integration analyst that works with you and your team to help make sure that that's a smooth and seamless transition. Third requirement for chronic care management is that you do provide a federally funded, well, we provide the federally funded hotline, but you're required to have a 24/7 nurse advice hotline. And that is provided. That's a Centene service. And NurseWise Evolve provides a nurse hotline that is available 24/7 to your patients. And that's just a requirement that the patients have access to nurse advice and that there is 24/7 access to their care plan. For example, what occurs is your patient calls into the nurse advice hotline. That nurse logs into LightBeam and pulls up the patient care plan so that they can see all the patient's data, and that's how they have 24/7 access to care. And in return for that, your practice is available to bill Medicare approximately $41 to $42 per member per month. That's per patient enrolled in your chronic care management program. And a little sidebar, if there are you identify 200 patients to begin with in your practice and you enroll them in the program, they literally, that's at $42. That's over $100,000 of revenue to your practice each month, annually, sorry. And that's a tremendous improvement. That's just one category. This just tells a little bit more about the chronic care consortium and the clinical health coach training, but it also points out that we have hands-on regional workshops that are held quarterly. Those are held each quarter. We actually just finished one up. I was leading a track of training on annual wellness visits and chronic care management all over the Southeast and East Coast, but I was just in Tallahassee yesterday doing that. But the regional workshops are a great place for practice managers, care coordinators, and in October we're inviting our providers to please join us so that we give them an opportunity to create action plans according to the PDSA format and go back. They have to identify one step, one change, one improvement that they're going to go back to the practice and implement that they've learned about. And it's very effective, but it also provides them with documentation and tools that they can use when you're ready to be certified for patient-centered medical home. And now, in addition to the 24/7 access to your patient's care plan that LightBeam offers, also LightBeam is an incredible quality improvement and data analytics tool. Anything that's on your claim, so you understand how you code your claim for quality, we capture that and we can help you aggregate your patient data and look at your quality scores aggregately across the board in two ways. It sort of reminds me of a meaningful use dashboard, and this dashboard aggregates for each provider. Imagine that you would have 6 providers in your practice, or nurse practitioners or physician assistants, and these are all of the measures that you report. And as you can see here, this very dark red line indicates that all of our providers are really doing poorly with depression screenings. And so that's an area that we want to address. That's just the picture version. In this on LightBeam is you can drill down all the way to the patient level. LightBeam also offers, in addition to care planning and quality, also offers risk per patient. It measures risk and risk stratification tools that are amazing. Here's just a quality metric, sort of a picture of the Excel spreadsheet that goes along with that dashboard in the list. So you can see the quality metrics that are measured. And this is through annual wellness visits. We have a strong emphasis when you're implementing a population health strategy. You start with annual wellness visits. Annual wellness visits through our model allows you to not only gather the data that you need for the baseline of the patient's health and to identify people at risk and that would be good candidates for your chronic care management program, but also to capture your quality metrics. All 11 standard quality metrics can be captured through the annual wellness visit. And through this annual focus on annual wellness visit, one of our hospitals actually had never measured before in the ambulatory side and with their physicians. And when they began to measure, they thought they were doing really well, and they only really measured at about 57%. They had never been able to pull this together in this format. Well, once they began to measure and understand what areas that they were weak in, and they worked on those, a lot of these, the measures, they didn't even need to be reporting. They just deleted some of those. They weren't required to report those measures. When they had a good look at it from the analytics side, they were able to and implemented their annual wellness programs and their screening, all of the screenings that they needed to do for these patients. They improved their quality by 20%. So this is a real live hospital, small rural hospital in California. So just a little bit more about our nurse advice hotline. We provide, on each of these topics, we provide incredible education and introductory education for your team to learn about each component of this program. And then, of course, we have our project management team and our IT analyst. And our quality, the fourth person I wanted to mention was the quality improvement specialist, who works alongside of your practice to ensure that you're meeting your goals and you're identifying aims and improvement, and that assesses your practice. And then we'll talk about that in just a minute. But NurseWise is not only necessary, but it also is a great marketing tool. When you have 24-hour access to medical advice, you know, that's a tremendous benefit and a great resource. Because quality, your quality score under MIPS is including point of service patient satisfaction, we are providing all of our practices with a tablet that's preloaded with some generic patient experience questions. So you can begin to gather data. It's real-time data, it's a survey, and it's not a CMS vendor certified survey. It's just your first step if you've never gathered patient experience or patient satisfaction data from your patients. It gives you an opportunity to see what their experience is in your practice. But those tablets have been deployed. It usually takes about 30 days to get those tablets out to you in your practice once you've enrolled in the program. And as I mentioned, this baseline assessment that we perform on all of our practices within 30 to 60 days of your enrollment, it is aligned with PCMH, Patient-Centered Medical Home aims. So 0 to 3 score. And it helps you to see, you know, where are we today and what do we need to do? Where do we need to go over the next aggressively year, you know, very slowly up to 4 years, you know. But you are remeasured, and that assessment is updated every 6 months. Our quality improvement specialist works with you to identify areas that you want to work on and sort of helps you identify and prioritize those. So at the end of the period of the Transforming Clinical Practice Initiative, your practice or clinic will qualify for patient-centered medical home if you've completed all the parts of the program. Of course, patient-centered medical home is where Medicare wants us to go. The proposed rule actually addresses patient-centered medical home and proposes that it may be approved as an advanced payment model. You know, this means that this is an opportunity for all of us, you know, that you don't have to be in a bundled payment program or a CMS-approved pilot or a Medicare shared savings program. It would be great, and we'll be learning more about that when the rule is finalized and announced before October. But as I said, we want all of our practices to be moving towards this model because basically it is the clinical practice improvement strategy that is going to be measured under MIPS, but it also is recognized by many of the plans, Medicare Advantage plans, commercial plans, and there are bonus payments for our practices that perform that. And in order to be aligned, we make sure all of our education and our workshops are PDSA format, and that's integrated and built into our program so that that's documented along the way. Now here is an actual chart of the clinical improvement activities, the measures and metrics that are going to be used under MIPS. And I feel like the reason I wanted to share this with you is because I wanted you to see and let you know how this program will help you qualify in each of the 4 categories. The same under expanded practice access is the first category, to have available time for same-day appointments, but also after-hours clinician advice. And that 24/7 nurse hotline does help you qualify for that if your doctors do not want to be on call for after-hours calls. Population management, the metric is monitoring health conditions and providing timely intervention. And that is very easily done through not only annual wellness visits and some of the population health screenings, but also transitional care management that can be coordinated through your care coordinator and your team. But that particular service is available for all Medicare patients that are discharged from an inpatient acute care hospital, a behavioral health hospital, a skilled nursing facility, or a behavioral health hospital. So that is a great way to monitor, to implement those programs and document that you're doing this. And also the other metric is participating in the Qualified Clinical Data Registry. We can help you create clinical data registries with your patient data in LightBeam. For an example, diabetes. We can pull all of your patients with a diabetes diagnosis and pull them into a registry and monitor their A1Cs there, just as an example. Under care coordination.
Hi,
yes.
Sorry, I have a quick question. So these 4 measures, all of these, the CMS requires that practices have all of these measures, that we do all 4 of these, expanded practice access and all of these four measure activities?
That is what's under the new MIPS program, yes.
Okay. Okay. All right.
And, for example, you probably, just like your measures under meaningful use, you probably have to choose one. You are, or 2. I don't think you're going to, right. So you're not, everybody's not going to have to use telehealth, but or use remote monitoring, but these 4. So you're going to have at least one of these, and I'm sure under the first year it'll probably just be one. And then, of course, a way to exchange information with your patients and providers is through a care plan. and through monitoring your patients with 2 or more chronic conditions. And then establishing a care plan. And this is the most important over here on the 4th category under beneficiary engagement, to be able to identify your complex or chronic patients, to establish a care plan that and get their signature, get them to buy in, to work with their care coordinator in order to prevent hospitalizations and readmissions. And then, of course, keep, yes.
Just one more thing. So basically most practices are going to need to have a chronic care coordinator.
Yes.
You know, a certified person. You're just going to need to have one. Okay.
And it's and as I say, this is sometimes even a medical assistant can serve in these roles. Registered dietitians, nutritionists are really good. You know, clinical nurse specialists. There's a range. Even patient educators do a really good job at this. But yes, it is a role for someone that'll be focusing in this area with these patients, and then teaching them self-management and how to assess themselves, how to weigh every day with CHF, and call me if you have gained more than 2 pounds in one day. You know, those are the kind of things, and employing shared decision making. So I think this is really a good example, because this is coming out and we don't even know we're going to be measured with this, you know, these measures, and that's what scares me, and that's why I include this slide that is, you know, not really part of our deliverable, but we have a deliverable to help you address each of these areas. And then just moving on, it's really the opportunity to look at your practice and how to implement and manage population health, create just a plan, including all the things I've talked about, starting with the, you know, real strong emphasis on annual wellness. And then where do we need to modify our workflow to address these care gaps? You know, I mean, how are we scheduling our annual wellness? How do we know if someone has had an annual wellness visit or not before they leave our practice? And so we talk about that, and we teach your team, your entire practice management and your entire team, how to look at the data, to understand how to sort of fill in the gaps there whenever we can, you know, look at dual visits, and we've got a sick patient coming in, how can we include, you know, bring them in early, keep them over just a little bit to accomplish that annual wellness visit, so we can gather the data. And gathering that data is so important in their diagnosis because of HCC risk scores. And are you familiar, have you received your letter from any of the plans on your providing you with your risk score?
I have not. No, I have not.
The HCC risk score is measured by all of the Medicare Advantage plans and all the Medicaid managed care plans, and they are, when you look on your contract and it says risk-adjusted payments, it means that they are measuring the acuity level of our patients by the diagnosis that we document. In other words, you know, are we documenting a sore throat and a cold, or a sinus infection, a cough whenever it's COPD, and, you know, it's exacerbated, and, you know, there are underlying comorbid conditions. So we also have a really strong focus on documentation and how it affects your bottom line. And all value-based payment models are risk-adjusted, do pay. That means if there's a bonus and it's risk-adjusted, that means if it's $100 and your risk score is 0.9, then you're only going to get $90. But if it's 1.5, because you've done a good job of documenting the acuity level of your patients, then your payment's going to be $150. So that's sort of how that works. But it's all about transforming your practice and your clinical practice activities in order to achieve value and deliver value-based services in a large curve that's going to equal up at some point by 2019. You're going to be offering as many value-based services and focusing on wellness and prevention as you are sick. And you're going to see your patients improve. But the beautiful part is you're going to be paid, and the wellness and the population health payments are more in most cases than your 15 and 30-minute A&M codes pay. So it's really a great, it's a good news, because you can add $225 to $300 to your per Medicare patient per year with these strategies. And then just summarizing, of course, these activities are designed to reduce cost and improve quality, but we really want to help you maximize your additional population health payment and prevent these value-based MIPS penalties and what they call adjustments, and then improve the bottom line. This is just one slide that says, we really do help you understand how Medicare measures cost on a risk-adjusted basis, and how they look, how a lot of the rural specific. And tell me where you are, what kind of practice. Do you have just an independent practice or group?
Yeah, it's independent. It's in Silver Spring, Maryland, and I'm definitely getting more Medicare patients as my population ages and retires. So yeah.
Oh, it's amazing, isn't it? How it's growing, and it's growing to by 2022, it's just going to be off the scale. And this is a concierge service that it really grows your market share too. It really brings, when you design these services and you begin to take care of these patients in the coordinated way, and you're looking at post-acute care, you're following them, when they're discharged from the hospital, all their providers, and they stay in touch. It's the way also that you've got if those patients cannot be attributed to other providers, when you are capturing and making sure they're in your office and you're seeing them. What we were, pardon me?
I just have a really quick question. So this slide, it says participation requirements. So these participation requirements are for the CMS MIPS program?
No, this is for the transforming clinical practice, yes. Gotcha. What I'm telling you is just preparing you to prevent a negative adjustment under MIPS. So everything that I've shown you, the light beam, the NurseWise, the care coordination, training and coaching, all the education, patient satisfaction, that is what CMS is funding in order to prepare your practice and get you ready for value-based payment reform and reimbursement. So, and there's really not any, other than having a care coordinator and participating, every cost is covered. There's no cost to you or your practice, including your travel to the regional workshops. If you're traveling 50 or 60 miles, you'll be reimbursed. So isn't that cool?
Yes, that's good.
And this is just participation, in the meetings is important, but also we have interactive webinars for each of these areas. We have a learning management system where all the recorded training is available to you. It's the minute you enroll. We have cohort calls, leadership cohort calls, as well as physician and care coordination. So it is a really neat program. It's very, very simple. It's voluntary. There's no legally binding agreement you have to sign. You can go to our website and following the I've got another meeting following, but in just a little bit, I'll be happy to send you this, Doctor, with the this link where you go to our website and just enroll. It's a little form fill. Probably takes 10 minutes. And
so
that's
even though I'm not, I'm sorry, even though I'm not a rural area, I'm still eligible for this?
Oh yes, we have because you're independent. We have a lot of practices. We just don't serve large, huge groups in large areas, large hospitals and academic health centers. You know, it's not our thing. We really do better with the smaller practices, and it doesn't matter where you are. Yeah, we serve a lot, but it's we have about 20% of our practices that are in urban areas.
Okay.
So, what do you think?
It sounds great. Another question I had. So I know the recording